Thank you everyone for joining us for our regular webinar series for Massachusetts AI and Technology Center for Connected Care and Aging. You're here at the right place if that sounds familiar. And so I'm going to turn it over to Jenna Marquand, who is part of our networking and mentoring and stakeholder engagement core. And she will introduce today's speaker, who should be a stellar presentation. Thank you.
Thanks so much, David. I am so pleased to have Joe Gaugler join us today. He is the Robert L. Kane Endowed Chair in Long-Term Care and Aging in the School of Public Health and a Distinguished McKnight University Professor at the University of Minnesota. I do want to point out a couple of things about him that are unique and important. He is the director of the Center for Healthy Aging and Innovation. And then the director of the National Bold Public Health Center for Excellence on Dementia Caregiving. The Public Health Center for Excellence on Dementia Caregiving is a CDC-funded University of Minnesota School of Public Health Center. And the goal of that center is to ensure systematic implementation of dementia care tools and practices by state, local, tribal, and other public health programs across the U.S. And then the Center for Aging, or Healthy Aging and Innovation, their vision is to provide a shared mission, vision, and resources for members across the university and beyond to pursue initiatives and become involved in activities that advance aging scholarship, education, equity, community engagement, and policy. And it connects particularly with Black, Indigenous, people of color, and people from other marginalized communities where help for older individuals may be limited. I am well aware of the work that this center does, and I'm going to put a link to it in the chat. I think it's an excellent model for a center that really believes in public engagement and all facets of scholarship practice, education, community engagement, policy work. So I encourage you all to look at that. And then, so Dr. Gaugler walks the walk on really caring about these issues. We were just talking about a goal that he's set for himself to visit all of Minnesota's 81 counties to both speak about Alzheimer's and other forms of dementia, talk about local resources, and letting people know what the center at the University of Minnesota has to offer, and then listens to people about what their local needs are. That's a huge lift and is a testament to the fact that he really wants to engage with all people in all settings. So I'm going to hand this over to Joe, who's going to talk about technology alignment with dementia caregiver needs, and caregiver needs being something that we've called out as particularly important and often overlooked within this space. So thanks so much, Joe.
Well, thank you, Jenna. Thank you to the Mass AIT Center for inviting me here, and for all of you for taking the time out of what I'm sure is a very busy schedule to spend some time with me and us talking about aligning technology with dementia caregiver needs. Unlike probably all of you or who are attending today, or perhaps many of you, I am not an expert in technology. Maybe I shouldn't do this when I speak. I always tend to, qualify my own, I guess, work in a given area, but certainly I am not someone who's well-versed or well-steeped in, say, gerotechnology, theories, models, engineering principles as it relates to gerotechnology, particularly in the space of dementia per se. Now, that being said, over the years, we certainly have conducted research, worked with many others as it pertains to technology and how it's applied in the dementia care context. And that's really what I wanted to focus on today upon Dr. Marquand's invitation, is to think about technology from the perspective and standpoints of dementia caregivers themselves. What are their needs? Are we meeting these needs? Where do we have to move our science and research forward to better address what are often very, very heterogeneous needs on the part of people living with dementia and their caregivers, particularly in home-based contexts? And that more or less is kind of the scope of the presentation today. I wanted to acknowledge some of the entities and groups of individuals that have supported this work and our work in the space of dementia care, my research program, Families and Long-Term Care Projects, the endowed chair that Jenna had mentioned before, and then the Center for Healthy Aging and Innovation as well. Also, I really wanted to thank the funding and extramural support that has made some of the research I'll be talking about today possible, specifically the National Institute on Aging, which has funded some of our work in technology, not only vis-a-vis our level grants, but also SBIRs as well. And some of the work we'll talk about today, at least some of the insights I hope I have gleaned have come from that work. Also, the Agency for Healthcare Research and Quality, which around a decade ago funded us to conduct a community-based trial on remote activity monitoring for people living with dementia as well as their caregivers. And I'll be presenting some of the main findings that emerged from that particular trial today as well. So there were really three goals I had for the talk today. Number one, what do we know about what dementia caregivers need as it pertains to technological support? What do they identify as how technology could help meet their needs? This seems like a fairly simple question. Maybe it's a question we all assume we know the answer to. However, I think it's important to approach this from the voices of caregivers themselves. And this first part of the talk, I tried to identify what I felt was some really recent, interesting work in this space that I wanted to synthesize and present to you, and then augment that with, I think, some of my own both observations as well as sentiments that have been expressed to me by families and caregivers themselves that we've engaged with over the years vis-a-vis our outreach work. Then I'll talk about the remote activity monitoring study where we approach technology as an intervention itself in the context of dementia care, and using a variety of methodologies, trying to identify why and how does technology work for people living with dementia and their caregivers at home. And then third, how we'll wrap up, and hopefully this will lead us to some good conversation and discussion. How can technology advance the state of dementia care science? So technology first as a support for people living with dementia and their caregivers themselves, which I think we'd all agree is of paramount importance. But then also, can technology actually advance how we conduct dementia care science itself, particularly dementia care interventions? And I had come up with some areas where I think technology might be able to push the field forward in that regard. So beginning with how can technology support dementia care? Generally, we understand this according to the following areas. Now, this is by no means inclusive. I'm sure many of you can think of other potential areas where technology could support dementia care, but by and large, when one looks at the literature, this is how technology is positioned as a support for people living with dementia. First and foremost, it can serve as a support for memory. Technology has been used, for example, to facilitate reminiscence or deliver reminiscence therapy in effective, person-centered ways. And maybe I should qualify effective, maybe more appropriate or feasible ways. Second is as an actual treatment modality itself, use of technology to, for example, manage or at least monitor certain symptoms that complicate the trajectory of Alzheimer's disease and its progression. Could be behaviors, functional capacity, etc. Safety and security in particular being a most common way technology is envisioned to support dementia care. For example, use of monitoring sensory systems, other types of modalities to ensure that the person living with dementia is safe, they don't fall, they don't wander, they basically trying to prevent or avoid those behaviors or activities that we know are often a trigger to a cascade of a number of other adverse events for people living with dementia and their caregivers. Using technology as a training platform, a way to deliver training in ways that is cost effective, that is maybe less onerous and burdensome than traditional approaches to training, as a mechanism for care delivery itself. I was reflecting and putting these slides together about recent developments in the space of dementia, and I'll be very curious to see the role technology plays. I would imagine some of you, maybe most of you, are familiar with the new CMS demonstration of what's called the GUIDE model. The GUIDE is, I forget what the GUIDE acronym stands for, my apologies, but essentially what the GUIDE model is, it's based on very, I would argue, strong or at least good evidence suggesting why collaborative, multidisciplinary delivery of dementia care can be effective in reducing healthcare costs, improving caregiver outcomes, et cetera. And so CMS actually put a payment uh, uh, program in place to facilitate the delivery of the guide model in healthcare systems across the US. And this is going to begin in July, actually. And so I don't know if we have the full list yet of those healthcare providers that were awarded contracts by CMS to deliver guide or are approved to be providers of the guide model. But what's very interesting about guide is there are, I think, 7 or 8 different pillars of the model that have to be delivered by each healthcare provider. And one area that providers have to address is not just providing collaborative care to the person living with dementia, but also incorporating or partnering with care partners, family members, or others to help engage in collaborative care planning, but then also to provide respite, support, and in some cases even training to those caregivers to help facilitate all the work and assistance that often takes place in the home environment. And why I think the guide model is intriguing in this context is I would imagine many healthcare providers might be contracting out with, say, companies that have used technology in innovative ways to deliver caregiver training, for example, or caregiving support. And I have seen some of those providers announce that they're involved with healthcare systems that actually will be delivering the guide model in July. And I think it'll be a real intriguing, real world experiment, if one could say that, of how technology could facilitate or perhaps not facilitate at all the delivery of collaborative dementia care in these contexts. Other ways technology can support dementia care, certainly via social interaction. An area of increased attention for many good reasons has been social engagement and social well-being in the context of dementia, and how that often is associated with a number of other negative health outcomes in the context of dementia. And so ensuring robust social engagement and interaction is another area or gap that technology could certainly, at least hypothetically, address. And again, there are many other functions here too. One that isn't on this list that maybe one could include is the ability to collect real-time data or more person-centered data in the context of dementia that maybe could better help tailor or target care services and supports. And there may be many others too. So what are some of the challenges related to technology use in the dementia care context? This was from a really interesting study I came across. I think it came out recently this past fall by Brookman and colleagues in BMC Geriatrics. And they actually did a really strong qualitative study where they interviewed both family and professional caregivers of people with dementia and really went in depth in trying to understand the challenges of dementia care and how these caregivers actually utilize technology in dementia. And first and foremost, what are some of the technological challenges that the literature has identified? First is the complexity of technology for many families. And the issues with trying to get technology set up and working properly, which again for many is not as easy as one would seem. Similarly, and related to this is familiarity or comfort with the technology. Many of these technologies that often are introduced to families or people living with dementia are often brand new. For many people when using them, and that can create some degree of discomfort for someone who's trying to, for example, establish a routine for someone living with dementia. This third issue is one that would seem intuitive, but again, I think when technologies are developed and deployed, aren't always considered, which is memory concerns with remembering to use the technology. I have worked with technology developers in the past where they've developed technologies, presumably for someone living with dementia, even someone in early stage, or even for mild cognitive impairment, that actually required the person to remember to do something as it related to the technology. And that could cause issues not just with not getting the most out of the technology in terms of its hypothetical or potential benefits, but then secondarily, it actually became another stressor for people living with dementia and caregivers themselves, which is, again, something that we seem to overlook in the technology space, perhaps too often, but nonetheless is a challenge for many families. I think this issue of troubleshooting is another issue. This has come up in our studies that we've conducted in testing and evaluating various types of technologies where, many families will give up using on technologies because they're not getting adequate support in troubleshooting. In the case of, say, sensors, maybe a sensor doesn't work. Maybe when it's placed in a certain area, it's too sensitive to motion or activity. There are many other examples. And in those cases, again, families are often overwhelmed or very challenged when caring for someone living with dementia. If a technology is introduced and it's yet another thing someone has to remember, yet another thing someone has to do, for many families, a really reasonable coping strategy to just say, forget it, I'm not going to use it anymore. Okay. I think this point is really interesting too, which is whether technology as currently constructed, how we're testing it, how we're evaluating it, does it truly adapt to the dynamism of the long-term trajectory of dementia? We know people living with dementia will do so on average from 6 to 8 years at point of diagnosis. Again, even now, diagnosis tends to happen fairly late during the course of the Alzheimer's trajectory. I'm sure many of you can point to, and we certainly see in our research, caregivers saying they've been caring for someone with memory concerns that really predates a formal diagnosis and can be for over 5, 10, 15 years, sometimes longer. Do we have technologies or technologies designed that actually can help and can adapt to the various transitions and changes that occur throughout the course of dementia? Or instead, do we have technologies that really are so targeted and focused that they're only useful for a fairly short period of time? I don't know if anyone has really answered this question of long-term use of technologies and their long-term benefit. Okay. And again, I could be wrong here. Maybe some of you are doing that now, but I haven't necessarily seen it done effectively in the literature that I'm familiar with. And then also, does popular technology marketed to the general population, does it actually meet the needs of people living with dementia and their care partners? And certainly, I think at first glance, many of us would say it really doesn't. Many of these technologies have not considered, if not even people living with dementia, older people in general, in terms of how they may use the technology, how it's useful, how it could be integrated into their day-to-day lives. That being said, and again, this has come up in some of the qualitative data, or certainly at least of my observations in working with families caring for people living with dementia in our studies, as well as vis-a-vis community engagement. Many people out there are taking technologies that were not designed for the dementia context and more or less adapting or modifying them to try to meet their needs. I remember one woman who was caring for her mother living with dementia at home. I was going to enroll her in the remote activity monitoring study, and she talked about how she took a baby monitor and basically used it in the context of trying to monitor her mother in terms of her getting in and out of bed at night, wandering, those kinds of things. I heard of other people using Alexa, particularly when it first came out, and trying to utilize that as a way to maybe, if not stimulate the older person living with dementia, to use it in different ways within the dementia care context. I think that's actually kind of an interesting scientific question. I'm not sure if anyone has really answered it. Less about we're designing a new technology and we're doing proof of concept work or feasibility, acceptability, and more about how are people using these technologies that are widely marketed, widely available, how are they actually using it to help support dementia care itself? That to me would be an interesting study. Again, forgive me if it's been done already. I'm not aware of it, but I think that would be another interesting approach. So in their qualitative data, Brookman identified these themes that more or less emerged from their in-depth, semi-structured interview methodology. First, many caregivers, both professional and families, indicated there was many needs for care recipients. Many of these we are familiar with. The need to help facilitate functional independence, social interaction, and manage behaviors. However, experience with technology use suggested that these needs weren't necessarily being met. There's generally low rates of technology use. There was some skepticism as to, will these technologies actually work for me or my loved one? And then finally, just as I had alluded to, there was also this tendency to adapt existing technologies versus seeking out those technologies that at least one would think or assume have been developed more specifically for dementia, aging in place, et cetera. So some of the design solutions, this is what I liked about this paper, and that they actually ask caregivers themselves, what are your solutions? What should technology do to address these challenges in the dementia care space? And first is technology to facilitate casual, regular social engagement. And I think I can vouch for this. One of our community outreach events that we've done this year will be, I believe, it's going to be our 17th year doing it. We hold an annual conference at the University of Minnesota called Caring for People with Memory Loss Conference. It is not an academic scientific conference. It's really a conference designed to provide education, tools, resources to families and care professionals who are helping someone living with dementia. And oftentimes we'll have people living with dementia themselves attending the conference to learn more about the disease, but also what they can do about it. And we generally will get 300 to 400 attendees, both in person at line as well as online at this conference. And one of the things that comes up over and over again in terms of what families want, and we see this in our feedback when we ask them what would be topics you'd like to address, is I want to know what I can do with my loved one. I want to know how I can engage with my loved one living with dementia. What are the activities I can do? And so clearly, I think this is what you're seeing in terms of caregivers design solutions as highlighted in this particular point. Secondly, and again, this relates to what's been seen in the literature, there's a need for technology that interfaces with existing technology. I would assume the right term here is interoperability. How that is still fairly lacking for many families, or at least it's perceived as lacking, and that's another issue. Finally, is the ability of technology to maintain personhood and identity with connection to life stories and relationships. Again, help technology as helping others realize and understand who this individual was, what they liked, what their preferences were. This is at the core of personhood, and I would argue person-centered care. And clearly, technology has great potential to facilitate and allow this. And this study I cited here, Garlinghouse et al. 2018, this was actually it was a fairly small phase 1 SBIR study we did. But it was one of my favorite studies I've ever done, at least certainly in the technology space, in that what we did is we used 3D printing, where we would work with residents in assisted living or nursing homes. Their family member would be there as well, as would a staff person. So we'd have these people in the room, and we would begin with a reminiscence protocol, a really basic reminiscence protocol to get a better sense of who this person was. What did they like? What did they enjoy when they were younger? What are some key life events or stories that resonated with them? And this being Minnesota, there would be things like residents would remember living on a farm. They remember a favorite car, a pet, etc. And then we would ask families or the residents, if they were able to share pictures or mementos of these special quote unquote objects in their lives. Then what we would do is we would go and have a 3D replica printed of that object, a pet, a farm, house, whatever that is, a car. And then we would share that with the resident, and they would get to keep that object. And then as part of the study, what we would do is we would interview the person, the family member, to talk about, okay, how did they feel about this object? And did it actually improve and enhance their overall social engagement? And I mean, the findings were really promising in what just simply having this simple object would do in terms of helping people living with dementia light up, start to talk about their past lives, engage with others, etc. I think that's a real great example of how technology can maintain, if not enhance, personhood, which again is such a critical goal when we're caring for people living with dementia. So a great colleague of mine, I'm sure someone you're very familiar with. I'll be honest, George Demiris is often my go-to expert when I am, for example, I edited a book a couple years ago, Family Caregiving, the Bridging the Family Care Gap, pardon me, that came out in 2021. And I asked George to provide a chapter, which he did very ably, on technology and caregiving. And one of the areas that George talked about at length, which was really helpful, was thinking about what are the implications of technology solutions in the caregiving and dementia care context. And he really highlighted 3 areas. We've already talked about caregiving burden and strain. And I think it's important to think about technology in this context as not just something that could potentially alleviate and reduce caregiving burden and strain, which of course is critical and a key outcome, but also ensuring that the technology doesn't contribute to it. And in the remote activity monitoring study, which I'll be getting to here shortly, some families, at least in the initial months of when they were adopting the technology, would talk about how there was a real acclimation period where the first few months it was challenging to get used to the system and its alerts, and it actually was contributing rather than alleviating stress. And so, I mean, I think that's a really key implication of the work in this space. The issue of how do we address consent and acceptance? How does consent operate in the context of technology? And also importantly, how can we work? What are the processes we should be aware of and put into place to facilitate acceptance and then eventually use of the technology? I mean, certainly I feel this way sometimes, maybe some of you do too. We assume when we have a technology that we're very excited about that it's a no-brainer that families will want this. It's a no-brainer that, you know, they will find it acceptable in incorporating into their day-to-day care routines. And I think more often that hasn't always been the case. Then third, a very critical point, this will come up again later, is health equity. How do we understand health equity as it pertains to access, affordability, use of these technologies? And are we doing a good enough job in ensuring that we are evaluating, designing these technologies with a health equity lens in mind? We had conducted a study back in 2019 where we actually had done, I want to say it was at least 8 focus groups with caregivers, professional, but then also family members of diverse ethnic and racial background. And each focus group, for lack of a better term, focused on a specific group. And in the Twin Cities area, these groups included, we had a African immigrant focus group. We included a Latina a focus group. We also had, I think we did at least 2 for Native or Indigenous and Native American communities as well, to get a sense of if hypothetically there were certain, in this the context of this study, precision medicine approaches to help diagnose Alzheimer's disease or treat Alzheimer's disease, would you want it? What would be some of the challenges? What would be some of the concerns? I chose to include and feature this work because I think there's a lot of overlap with technology as well. And certainly precision medicine in terms of how it's delivered is often delivered vis-a-vis certain types of technologies. And I thought the themes that emerged were very interesting for these communities. First, the issue of cost and insurance coverage and how this new approaches or technologies would actually be feasible for them. I mean, I think it's a key issue. Second is, does the technology align with cultural norms? Again, whether these questions have been effectively answered in the space of technology and dementia, I'm not sure. But clearly, this would be an area I would argue of great need. When we design, create, test technologies, do we have cultural norms? Are cultural norms incorporated in that design process and evaluation process? The issue of fraught relationships between communities, health professionals, and researchers, how will that affect the delivery and use of technology in the space of in the context of dementia, which is important? Who owns the data? How private is the data? I think has great relevance in the context of dementia. And then the trade-offs between knowing risk and treatment benefit. Admittedly, this is more relevant to the space of precision medicine, but I thought it was still important to note, depending on the types of technologies that we're planning to test and evaluate. So I think that gives us a fairly good overview of what are some of the, again, self-expressed challenges of using technology in the context of dementia, and also the implications of technology. And I wanted to switch gears now for this part of the talk to summarize some of the findings of a trial that we had completed a couple of years ago on remote activity monitoring for people living with dementia and their caregivers at home. And really, the study had the following broad objectives. One was to determine the effects of remote activity monitoring technology on the well-being of family caregivers of people living with dementia. For example, did it improve their feelings of self-efficacy in caring for someone living with dementia? Did it alleviate depression, stress, etc.? And then secondly, we wanted to determine the effects of what we'll call RAM technology on people living with dementia themselves. Did it, for example, reduce health service utilization or falls or other key outcomes from the standpoint of the person living with dementia? There was a big team that contributed to this work. You see many of them listed here. Again, they contributed their expertise in many different ways. You'll see shortly that this was a mixed methods embedded trial. So we utilized the expertise of both qualitative and quantitative researchers to help make this trial happen. This was funded by an R18 grant from Agency for Healthcare Research and Quality. It was funded from 2014 to, I believe, 2019. And so you can see the clinical trials registration there too. Now, admittedly, this technology is probably very much outdated at this point. I mean, when we started this study, remember, that's 10 years ago. And so many of these sensor types either have advanced greatly in terms of their use and their interface with other devices, for example, smartphones, et cetera. But nonetheless, the basic gist of these sensors are similar to, I think, many of these monitoring systems that are available today. They essentially identify whether expected activity or unexpected activity is occurring vis-a-vis a series of ADLs, activities of daily living. And then if something is happening that is not expected, as learned by the algorithm of the sensor system, the system then issues an alert. And in this case, we set it up where the alert would go to the family caregiver or other individuals the family caregiver would identify that should be alerted. For example, if someone's getting in and up out of bed at night, if someone was flushing the toilet multiple times during the day, if they were opening a door that likely shouldn't have been opened to the exterior of the home, and et cetera. And that was basically how this system was set up in the context of this particular study. This here is just similar to what I already talked, kind of really in simple fashion, is showing you how the system works and how it would actually issue alerts to, in this case, again, a caregiver. Now, this technology is used in residential care settings, for example, assisted living or nursing homes. Although, again, my sense is even while we were doing this study, this particular company that had developed the technology had been sold multiple times, was called different things. Eventually, Best Buy, I think, bought it. I'm not sure what the status of it is now. But again, my sense as well is this type of system has evolved considerably over the past decade or so. But nonetheless, I think the overall objective of what these systems are trying to do remains the same. This more or less shows you what the design of the study was. Again, it's called an embedded mixed methods study or evaluation, where if you look in the upper left-hand side here, this is the randomized controlled trial component of the mixed methods study, where we randomly assigned dementia caregivers to either receive the technology or not. This actually included a follow-up of up to 18 months, where we assessed caregivers vis-a-vis surveys every 6 months. So we had up to 4 points of data on each participant. You can see some of the key outcomes there that we considered. Caregiver efficacy, competence, and stress. The other thing the slide doesn't show, the other key outcomes where we also had caregivers report on key health transitions or health service use variables to get a sense of, was the technology actually having an effect on these care recipient health service outcomes. Now, the other thing we did, and this is where the mixed methods comes in, if you look at that oval, the embedded process evaluation, every 6 months for the treatment group, we would administer what we called a treatment review checklist. We developed it specifically for this study, and it includes a series of Likert items that more or less assessed perceptions of utility, acceptability, appropriateness of the technology, but then also included open-ended questions to get a better sense of how well the technology was working for caregivers who were assigned to the treatment group. What were issues, what were challenges, what were barriers? And then we use the treatment review checklist, particularly the Likert item scales, to then identify a subsample where we conducted semi-structured interviews with them. There were 30 of these caregivers. We essentially stratified them as to those who basically perceived the utility of the RAM technology as high versus those that had more moderate or low perceptions of utility. And we conducted semi-structured interviews to really go beyond whether the technology worked and to get a better sense of how and why did the technology work or not. For whom did it work? And for whom did it work better than others? And as you'll see shortly, we use that mixed methods qualitative data to refine some of our quantitative evaluation results. This just gives you some real quick background here of the caregivers and care recipients in our sample. Well, I mean, it was more or less fairly evenly divided between spouse and adult child caregivers. Most of the care recipients living with dementia did live with a caregiver in our study, but roughly a third or so, well, less than a third, pardon me, maybe 1/5 actually did live alone. And so families were using this technology for that very interesting subset of people living with dementia. The lower right-hand side, I apologize for the acronyms, but the first two acronyms is the Revised Memory Behavior Problem Checklist, both caregiver reaction, and then F stands for frequency. So you can see fairly frequent behaviors were occurring in this sample. Caregivers tended to react, I think, modestly with stress. In terms of cognitive impairment, this is a modestly impaired group of care recipients. In terms of function, again, being that these are care recipients living at home, their activity of daily living function was not as extensive as, say, a residential care population. However, there were instrumental activity of daily living dependencies that were indicated. So first, what did the qualitative data show us? And you can see these were the main themes that emerged from the qualitative. We did an overall qualitative analysis of how and why did the RAM technology work for dementia caregivers. And you can see the main themes that emerged here. Interestingly, many of these align with what we talked about earlier, didn't they? The need for ongoing technological support. One qualitative piece of information that came up over and over was the value family members placed on having a human that they could talk to help them navigate the use and acclimation to the technology. This longitudinal element, which again, I think having an 18-month follow-up really allowed us to look at a little bit more, which was how did the system work in terms of the progression of dementia, shifting life contexts or transitions that occurred, as well as identifying an adjustment period where over a certain period of time, caregivers became more acclimated to the technology, but it didn't happen right away. Here are some of the quotes that emerged from those three highlighted themes I wanted to show you, starting with the adjustment period. Some of the charts were difficult to use at first. And when she means charts, she means the system also had a online interface where families could actually look at charts and look at activities, the activity patterns of their relative living with dementia. So what Maria said, they were difficult to use at first, but I learned how to read them eventually. Here you see an alternative reaction where I tried to use it in the beginning, but it was just too difficult, so I gave up. I felt like I should have been able to figure it out, and when I couldn't, I stopped asking for help. So really, again, this idea of there's a threshold, I think, for caregivers that if the technology isn't working, they're just not going to use it. And scientifically, that's problematic. For example, from a treatment fidelity perspective, of course, this is an intervention study. But even more importantly, I would argue, is thinking about the true use and utility of this type of technology and how we really need to adopt a longitudinal perspective to really understand it. Next, the theme of ADRD progression or Alzheimer's disease-related dementia progression came up. And so you see here, the alerts are the most useful tool in the system for me right now because my mother's dementia is advanced so that I have to be at her home every day or at home with her every day. So the day-to-day monitoring from my computer isn't as crucial, but the alerts let me know what's going on and if issues of concern come up. And then alternatively, the disease progressed in a way where, the system wasn't helpful. He doesn't wander. He still has really good judgment. He's declined, but in ways different than I anticipated when I enrolled in the study. So Heidi, again, all these names are changed, by the way, but Heidi enrolled in the study to protect confidentiality, but she enrolled in the study because I think she expected and anticipated a different trajectory of decline that actually happened, which I think is pretty interesting. And then finally, shifting life context. And in this instance, and in this theme, in fact, it showed that the RAM system really wasn't that helpful in terms of helping navigate transitions. In this case, for a caregiver saying, I was laid off from my job, and I currently work part-time from home, so I'm at home all the time anyway, I don't need the RAM. And then finally, we go up to the lake 3-4 days at a time. We go out doing other things. I had a heart attack. I was in the hospital. There was never any kind of reaction from the system. So in this case, the system just wasn't working the way it was supposed to. We never heard anything, never called, never anything. So even though we did proactively follow up with all carriers to check in, how's it going? What can we do? In this case, still the level of technical support was such that this was another caregiver that really felt the system wasn't working for them. Now, when we actually looked at the quantitative data over the 18-month period, we found, in fact, that when we did kind of a traditional empirical analysis, there was not any effect over the 18-month period on any caregiver outcome. Now, however, we did do a preliminary evaluation prior to the full evaluation of data where we were looking at 6-month data. The reason why we were doing this is at the time when we were conducting the study, there were certain policy activity or actions that were taking place in different states where they were actually allowing Medicaid waivers to pay for this remote activity monitoring. And we wanted to be responsive to that. So we had a fair amount of data. We had roughly at the time, I want to say 120, 130 caregivers who had completed at least 6 months of data. So we actually wanted to do a preliminary analysis of the outcomes at that time. This is not often recommended from a pure trialist perspective, but we felt that because of the real world context where this study was taking place, we wanted to respond and show, does this technology actually work well for dementia caregivers? And in fact, over the 6-month period, we found some really interesting results. And to me, I wanted to highlight for you why mixed methods can be so powerful when evaluating technology in this way. Similar to the 18-month analysis, when we looked at the direct effect of the technology on outcomes, we didn't really see anything happening on the key caregiving outcomes. However, and you saw a little bit of this when we looked at the qualitative data, for example, the open-ended data that was available on our treatment review checklist, we found that caregivers were indicating in certain situations, the technology seemed to be more helpful than in general. And so what we did was taking that qualitative data, we identified potential moderators of effect that we then plugged back in a series of interaction analyses in the main quantitative outcome or in the quantitative in a post hoc quantitative analysis. And what we found was empirical findings that more or less were aligning with those qualitative insights. For example, if you look on the upper right hand side here, essentially what we found was that caregivers who utilized the technology and the individual had less cognitive impairment, so they weren't as impaired, they actually indicated greater self-efficacy over the course of 6 months. Similarly, if you look on the lower left-hand side and look at the rate of change here in particular, the significant interaction that emerged was for those who utilize the technology and were caring for someone who was having a lot of difficulty navigating the home. This was the closest empirical item we could find that simulated wandering. We found again for them that they indicated a greater sense of competence over the 6 months when compared to the other subgroups of carers who actually indicated either stability or decline in that particular outcome. So again, understanding for whom, how our technologies work is really important because in many instances, hoping or getting a pure direct effect can be challenging, particularly in a real world context like this study, where we were just looking at dementia carriers who were living at home with their care recipients. And using mixed methods as a way to do that, I think is a powerful tool that can be utilized. We also did conduct analyses on health service outcomes as reported by dementia caregivers, and we actually found some interesting effect. When we looked at the full 18-month data, we found caregivers would indicate less frequent falls in the prior 6 months in the treatment group when compared to controls. And similarly, fewer caregivers indicated emergency room visits in the prior 6 months or the 6 months prior to the 18-month interval than those in the control group. And when we actually adjusted those models with covariates, those results more or less held. The falls is on the border, of course, maybe not even, it's a little bit over 0.05. But again, we saw this trend continuing to emerge. Now, one thing that was interesting, you just heard me go on and pontificating about the benefits of mixed methods. But when we actually published these outcome results and we published it in JAGS, the Journal of American Geriatric Society, as I believe a brief report, the editor actually asked us to take out the qualitative themes or quotes. We actually had included this as part of our main paper. We thought it would give context to these findings and explain why these findings were occurring. But for a variety of reasons, we were asked to take this out. But I wanted to present them to you here because, again, I really do believe they shed light onto why one would think that this type of technology would operate effectively for dementia caregivers. And you see here in terms of falls, I'm sure we prevented falls. It didn't prevent them all, but I'm sure the fact that I got the call and they were immediate, it allowed me to more or less be more proactive, okay? Secondly, it was so effective in waking the caregiver at just the right time, just the amount of time to get to him that we, knock on wood, decreased the opportunity for falling tremendously. If there's something with too much of a lag time, that's when falls occur, you know, by the time the caregiver gets there and he's on the floor. And then again, another caregiver talked about falling. It's important, the wandering thing. It saved me a couple of nights that it was kind of, you know, you get scared, but I was warned and had enough time to fix the problem. And similarly with the emergency room visits, there's one time that I didn't hear her fall and she had fallen, so I was alerted immediately. So that could have been bad. So in this case, the caregiver then I think, was able to address the situation versus it getting worse. And then similarly, because when she fell, she could automatically, if she had her old button, she could automatically have been sent to the ER rather than alerting me immediately to know about it. So again, I thought these qualitative findings helped at least provide some insight as to why we were seeing the empirical results that we did. So what does all this mean? Caregivers utilize an integrated technology really in diverse ways, which is fitting with the diversity and heterogeneity of the home care context. Again, this point of the need for the technology changed over time, and it was highly reliant on family context and severity of dementia. Again, and many of us ascribe to understanding dementia and the dementia care context via a socio-ecological model where there's multiple levels of influence and how dementia progresses, how caregiving progresses, et cetera. And certainly when considering technology and when it's integrated in the home-based context and not a highly controlled context, that certainly was evident. The other point I think is important to note, we've seen it in this study, we saw it in other studies where we tested other technologies, where again, dementia caregivers really highlighted the need for a human to provide ongoing help and assistance when trying to use and navigate the technology over time. We've talked a little bit about why the technology could potentially prevent adverse health events for people living with dementia in the community. And again, so I don't think we need to go through that. There were certainly limitations to this study, though, and I think we should be honest with ourselves. The sample was not representative. It was very much a volunteer-based sample. Because of how this was funded and the amount it was funded, research blinding was not possible. I actually had to serve as the coordinator of the study for the first, I don't know, year, 2 years of the project. And so that precluded the ability to do blinding, which was unfortunate. I think questions remain about the fidelity of this type of intervention. There were instances, again, where caregivers clearly just stopped using the technology in the treatment group. And so that raises questions as to, how do we actually monitor and assess what does fidelity mean in the context of using technologies of this type? There was some differential loss to follow-up, although the overall loss to follow-up was fairly low over the course of the 18-month follow-up period. I think the conclusion from these findings, I've talked quite a bit about this here already. No need to reiterate this, except for the last point. Now, again, forgive me. And I know as editor of the Gerontologist, apparently there are some measures that are currently under development that address this. I'll be very excited once they get out into the field. One of the things that I think comes up a lot for families and people living with dementia, again, admittedly, this is observational, so take it for what it's worth, is some families feel overwhelmed with the number of technologies that actually are available that they could purchase or use to help support their loved one living with dementia. Have we developed a way or approach to match the right type of technology to a caregiver and person living with dementia with a certain set of needs, living in a certain context, that we feel fairly confident could result in positive outcomes? I have not seen many studies do this effectively. One exemplar that did do it well was the Attila trial, which I believe took place in the UK. Actually, even predated this trial, so it's a little bit older now. Where they had a really comprehensive process. This study, if I recall, wasn't necessarily testing one kind of technology. It had like a suite of technologies that would be identified and matched to the needs of participants in the trial. Now, unfortunately, the trial didn't show many positive benefits, but one thing that intrigued me was the protocol they utilized to match the person living with dementia or the user of the technology with the certain types of technology. It was very, very rigorous and I thought interesting. And again, from my understanding, measures are underway being validated to do exactly this. This to me is another important area of potential focus when we talk about aligning technology needs in the context of dementia. I wanted to just wrap up the presentation. Hopefully we have some time for conversation and discussion. reflecting on what are our next steps when we think of the science of dementia care and technology. I always find it useful to review the NIA's research implementation milestones in AD, ADRD, and dementia care. And the ones most specific to technology is this 13A to 13R milestones, care and caregiving, technology-based dementia assessment and care, which is milestone 13.I. This actually has been determined as have been achieved. And again, those of you here are part of the successful accomplishment of this milestone, which really in the end was building effective infrastructure to better understand, again, how technology can help meet the needs of older people and their caregivers, and also how it can advance science itself. And that certainly is epitomized by the very robust support the A2 Collective, Mass AITC, has provided to many, many investigators to pilot work in this area. You know, I don't know if all of you are familiar, but the Journal of American Geriatric Society put out a collection of articles commemorating the 50th anniversary of NIA. And one of the articles was by Rose Lee and their colleagues on the A2 Collective. And it was a really nice summary of, again, the great work of this collective and how it has served as such a critical piece of scientific infrastructure to maybe and hopefully begin to address many of these areas of need and gaps and opportunities that hopefully became evident today in my talk. Last thing I wanted to also reflect on, and I think when we're doing research in technology and dementia, it's really critical for us to think about the National Research Summit recommendations, and one specifically focused on technology from last year's Research Summit, which again, and you heard me talk a little bit about this before, the critical need to understand health IT consequences and disparities. How can health information technology be leveraged to improve care access, quality, and costs, particularly for those that are traditionally underrepresented? And you can see the 4 research ideas that were proposed as part of this, which or 3 at least, areas which I think are very, very interesting, align with some of our earlier work to some extent, but would be really important for us to better understand as we try to advance the science of dementia care and technology. I just want to conclude then from my thoughts when I think of technology, and one of the areas I think is really interesting to consider. Certainly, again, the most paramount issue is how can technology be used to benefit people living with dementia and their caregivers? I think many of us would agree with that. But I've also been thinking a lot about how can technology be leveraged to actually fill the gaps in dementia care science itself? I mean, and I listed some of the gaps that I think come up over and over again when we try to understand why certain innovations are effective or not. What are some of the issues with lack of rigor in trying to determine that? And these are some of the areas I would argue that maybe technology can help provide some answers. For example, how do we assess fidelity in dementia care interventions, particularly in real world, whether it's pragmatic trials, implementation studies, et cetera, versus having to rely on very onerous assessments of fidelity that really don't mirror the real world at all? How can technology be used to better capture person-centered measurement? One thing I think is evident, at least to me, is many of the measures we actually use to assess efficacy for dementia care interventions don't necessarily match or reflect what's important to people living with dementia or their caregivers who participate in our trials. Can technology be used to better craft more person-centered real-time measures? Can technology be used moving beyond proof of concept or feasibility and acceptability studies? Can it help us understand not just whether an intervention works, but how or why? And then finally, we know in dementia care intervention, many of the interventions that indeed are efficacious tend to be the ones that include multiple components, which kind of makes sense at one level. If you include a bunch of things in intervention, the chances of influencing an outcome probably go up to some extent, but that also hinders scalability. It hinders implementation potential of these interventions. Are there ways we could apply and utilize technology to better scale up interventions? Maybe help us identify which components are driving benefit and effect, and then really trying to galvanize all of our efforts when implementing an intervention on those key components versus this kitchen sink approach where, you know, if we're going to implement this intervention, you got to do it all, because that's the way I tested it in my randomized controlled trial. That is not feasible. That leads to a very leaky translational pipeline. The last thing I'm going to leave you with, and we can talk about it if we have time today, I'm not sure. I certainly encourage you to email me. The gerontologist is actually planning a special issue on AI and aging. And I think there's no one better to think about, number one, what this issue should focus on. And number two, there may be some of you in the audience who might be good special guest editors of this issue. But I'd like you to think about, and if we have time, we can talk about what would you like to see out of a special issue on AI? What do you think it should focus on? And who would be the right people to potentially lead that particular special issue? I'll stop there. Please do follow us. I'm going to share these slides. Hopefully these slides are all shared with you. These are all hyperlinks to our different initiatives. Please get in touch with us or me. Always happy to talk with you more about the great work you're doing. So thanks again, everybody.
Thank you so much, Joe. And again, I know we're a little bit short on time, but I know you are more than happy to have folks reach out to you individually. And I don't know if you have a hard stop right at 3 o'clock, but I think you've posed an interesting question to the group that if anybody has any thoughts about this special issue and what the topics that might be helpful would be.
Thanks. I have some time here, shockingly. I apologize if you don't, but I'm happy to, happy to talk more if you'd like.
Yeah, does anybody have any quick questions that they've got? Otherwise, I've always got some. Deepak?
Yeah, no, first of all, I wanted to thank you for the talk. It was fascinating, great work. I'm one of the leads of the center. So yeah, I mean, I think the gerontology special issue sounds great. In fact, GSA has a couple of other special issues that they've been talking to us about. As you can see, there's a lot of interest in the space. And I'm also curious from your perspective, just given the 5-year study you did, do you think if that study were moved to now going forward, do you think what would change? What would you change about it? And obviously, the technology itself has changed somewhat, but it's doing the same thing in a way.
Yeah,
right?
that's a great question, Deepak. The parallel I would draw with, say, that type of trial, really any trial in technology and dementia care that I think we should all be cognizant of. The parallel I draw is with implementation science, and a big emphasis on implementation science that isn't always followed is assessing organizational readiness. And what that means is prior to trying to implement an intervention in a given partner, healthcare setting, wherever, is assessing, is that organization ready? Does it have the capacity, the self-efficacy to actually implement the intervention? I would argue a similar issue is needed, say, for example, readiness for technology use that should be administered and assessed for caregivers as well as people living with dementia. Even more so when these types of studies go beyond highly controlled, heavy inclusion-exclusion criteria type of study, a stage 2 type of trial, vis-a-vis the NIH behavioral stage model, and moving into real-world contexts, where you're going to be conducting this work in very diverse, heterogeneous, quote unquote, messy contexts, understanding if who you're working with actually has the capacity and willingness and understanding to use the technology is critical. We did not do that in this trial. Had I had the ability to do it again, that is something I think would have been very important to consider. Secondly, related to that too, is, and again, I didn't understand or know this when I proposed this study over 10 years ago now, is thinking of the design itself of the trial. It was very much, even though it was mixed methods, which was a big benefit to this study, it still was conducted as a fairly traditional explanatory trial, a 1-to-1, you're randomly assigned a treatment or control, you get the treatment or control, and then we're going to just follow you for 18 months, et cetera. In the case of technology, when you have these issues, say, of problems with using the technology, or not able to use the technology effectively, there are probably better designs to consider than the traditional randomized control trial. For example, maybe a smart design where, again, if you periodically are identifying acceptability and use of the technology, if it's not working for certain subsets of your sample, is to randomly assign them according to their use or acceptability or something like that. If any of you have seen a smart trial and what it looks like on paper, it kind of looks like almost like a logic tree, right? Where at different points you're randomly assigning your sample based on it could be outcome, could be on assessments of acceptability, et cetera. That would have been another design if we had the power and ability I would have liked to have applied here, because clearly there were some caregivers, they just stopped using the technology. So in that instance, it would have been nice to maybe re-randomly assign them according to maybe a technology they found more palatable.
I think Misha has this.
Yeah, okay. Hi, I'm Misha Pavel,
Yeah, sorry.
Northeastern. Hi. Thank you for your very nice presentation. One thing I'm concerned about is that a lot of us talk about using technology as if it were a well-defined concept.
Yeah.
And what we need to do is something that happened in engineering and other areas to actually understand the underlying principles, build models of what it means to be going through ADRD and then apply aspects of technology that are appropriate for. So I wonder if you can comment on it.
That's a great point. That it's an interesting question though too. When I think of, and again, I'm thinking of this maybe even beyond research and just the families we've worked with, the thousands of families we've worked with over the years, often over many years when they engage with us and we know them. Can you actually engineer a model of ADRD progression that's applicable to each person? Do we have the technology to do that? I want to say I'm skeptical and no at this time, but with AI, who knows? Maybe there is a way to do that where we actually achieve the ability to tailor and personalize, whether it's technology or really any other type of intervention, recommendation, treatment, et cetera, that can best meet, again, these very diverse, heterogeneous needs of families in the community. Maybe, this engineering approach is a way to do that. I don't know how I would do that. That's beyond my expertise, unfortunately. I will say this, however, you mentioned engineering principles. I think engineering principles can teach us much about how we, beyond technology, teach us how we evaluate and design dementia care interventions themselves. Again, a major problem in the science of dementia care, which you heard me allude to, is we often don't know what elements of our interventions actually are driving benefit. They tend to be very complex, very unwieldy. We don't know the how or why these interventions work. We might know whether they work, but we don't know how or why. And I believe that served as a major, major barrier to disseminating and implementing innovation in dementia care. In other areas of behavioral intervention science, there have been, again, design approaches that have applied engineering principles to more or less decompose complex interventions and give researchers insights through a variety of testing approaches, what combinations of components of, let's say, a multi-component intervention actually work and why. And so when one actually progresses through the traditional life cycle of intervention development, from design to testing to, say, efficacy trial to eventual dissemination implementation, by the time you get to those latter stages, you can feel fairly confident that you have an intervention that's scaled in such a way that it has much higher implementation potential than the usual way interventions are disseminated and implemented, which is, we do likely a trial that has no real-world applicability or limited real-world applicability. It's tested. We get it published in a journal because it's a randomized controlled trial. Then when we actually try to get it out into the community and scaled up, we can't articulate how and why the intervention works. We can't say what can we adapt or change in the intervention to ensure that it works for, say, different resource contexts, but is still effective. And hence we have this very, very leaky pipeline where only 14% of that evidence-based innovations actually reach actual implementation. And it takes around a 20-year period to do that. I realize I'm not totally answering your question, but when you say engineering, it leads me to that particular tangent. So thank you. But I do kind of acknowledge your initial question. And
Thank you.
yeah, I mean, it would be a fascinating thing to do. Would it have utility in the day-to-day lives of caregivers and people living with dementia? That to me is a whole entirely other question. I'm not sure. Jenna mentioned, I'm sorry, Jenna, please.
Oh, sorry. Yeah, finish your thought, Joe.
I was going to say, Jenna, you talked about these county visits, and, I've talked about this annual conference I do. And so again, I hear a lot from families when they share their experiences with me about what it's like, the problems they have with, working with primary care providers, the lack of resources, et cetera. I have to be honest with you, and this is not to be disparaging because they don't talk about evidence-based dementia care interventions either, which is what I do. No one talks really about technology at all. I've never had a family raise their hand and say, can you tell me about this technology? Can you tell me, can Alexa? No one mentions it. It's not like on front of their mind. I don't know whether that's good or bad, but I think it's important to note.
Great.
Yeah.
It's great to note. That's,
Yeah, I mean, and there's an opportunity. Maybe it's because it's not thought of as, maybe it is a support that could be utilized, or maybe, Misha, it's related to maybe, maybe our definition of technology is too limited. I mean, and really, a microwave is technology. The TV is technology. A cane or glasses are technology, really. I mean, if you think about it. So, but yeah, please, Laura, I'm sorry.
Thank you. Thank you for the presentation today. During your presentation and others, we talked about the importance of medical things like falls and emergency room visits as criteria for evaluation. Since the study that you talked about, we're now moving into care in the home to a much greater degree. And we're also looking at value-based care as opposed to fee-for-service.
Yeah.
So I'm interested in your comments about the difference between information that would be destined for the caregiver versus information that would be destined for a healthcare provider.
Well, I think the counter to that for me, let's say you talk about value-based care as an example in this space. If you're talking about value-based care, you're talking about what interventions or approaches would alleviate these costly health outcomes like falls, like emergency room use, like institutionalization to a nursing home. We just published a meta-analysis actually that evaluated the literature, all the trials that we could find on what would prevent nursing home admission. And one of the modalities that seemed to be most effective were actually inpatient geriatrics. And why? It's intensive, multidisciplinary, collaborative care planning to help facilitate transition from hospital to home, essentially, I would argue. I mean, those are probably many of the core elements of successful geriatrics, particularly delivered in inpatient units. So, with that in mind, and you see this with the guide model, Laura, and it's recognized, particularly in the context of dementia, to effectively achieve the outcomes you're talking about. I don't think you can do that without including a caregiver and not targeting their outcomes. I think a failure, or at least a gap in how healthcare has been delivered to people living with dementia, quite frankly, and how it's been evaluated, is if you're targeting either or, you're not capturing the full picture. When you talk about at-home care, one thing we do know is that 83%, I believe, of all older people with dementia, they rely solely on an unpaid individual, most often a family member, for care and assistance. If you're going to deliver any type of, whether it's technology or other intervention in that context, if you are not incorporating a caregiver, if you're not identifying them, I would argue you are limiting the overall, if not impact and benefit, sustainability of your particular approach. That would be my counter and answer.
Thank you very much.
Yeah, thinking of this as a target at one or the other, I think has inhibited us for many years. Look, I'm guilty of this. I do this in my own studies. I target caregivers a lot of the time, my interventions and outcomes, but is that actually capturing the context of dementia care at home? And I think we all know the answer. The answer is no.
We'll take one last question, Jan.
Yep.
Hey, Jenna. Firstly, say hello. Yeah, Jenna actually moved from our department to University of Minnesota.
Yes.
Nice to meet you here. So Joseph,
Wonderful.
I have a question, because you mentioned the gaps in the dementia care science. You mentioned the fidelity assessment, person-centered assessment, measurement. So I really like these topics. But for my understanding is, because we use AI, that means we want to quantify the data, like we quantify the fidelity, like for the assessment purpose. But when we talk about person-centered management,
Mhm.
it's like a kind of translation from subjective thing to objective, like translated to the data, right? So when we have to face this kind of issues, we have to think of this is like a person-centered. That means you need to consider some kind of subjective issues related to disparity, like in culture, like family, some many things related to
Yes,
person.
yes.
So that's very difficult. I want to hear your comments, in the future, how can we get this kind of research to be more reasonable, based on your experience?
Well, yeah, I mean, so there have been and there are validated ways, I would argue very validated ways to get at person-centered outcome measurement, say in dementia care. One approach that it's been around a long time, actually, it's been around since the 60s and was done primarily in psychiatry. That's where it was originally designed, I believe, at the University of Minnesota. It's an approach that Dave Rubin and his team have used very successfully in their collaborative dementia care models at UCLA, which is called goal attainment scaling. And what goal attainment scaling does is it basically allows participants to identify their particular goals in participating in a given therapy, or in this case, in an intervention. And then there's a scoring approach that's done to more or less quantify whether the intervention has met this person-centered objective of participants. I don't know if technology has been used to facilitate the use of goal attainment scaling, but again, you can see its potential utility in the context of measurement of outcome in dementia care. I don't know if I'm totally answering your question. I mean, one of the things, one of the things to understand about fidelity measurement, which I think is interesting, if you look at the actual definitions of treatment fidelity, particularly in behavioral intervention, you are right. Much of it is quantifiable. Was the intervention, what was the prescribed number of sessions delivered? Were they delivered over the time period prescribed, et cetera, et cetera. But there are also elements of treatment fidelity, domains of treatment fidelity measurement that actually are more subjective than you would think. How well was the intervention received by participants? Did participants actually enact the recommendations given to them by, say, an interventionist to deliver a given intervention? Now, I guess you could measure that as a simple yes/no answer, but in fact, the reality is people may have enacted recommendations of a given intervention to greater extent than others. This is where it becomes very complicated, I think, to assess these things and sometimes to simply quantify them.
Yeah.
The other thing too, go ahead, please. Sorry.
Yes, thank you for the comments. I think my concern is more for like when you quantify it, for example, using scoring methods, the problems mostly, my concern is about the disparity about the person. Different person may have the disparity because of the cultural background, because of family issues, something.
But
right?
this is what, yes, but this is why I would argue something like a goal attainment scaling approach, which allows the participants themselves to define the outcomes important to them, I think can at least in part address these disparities you're talking about, which definitely are present. Like the measurement of caregiving burden, again, the most common outcome measure in dementia caregiving, we know that the concept of burden is not culturally relevant amongst many communities. So, I mean, the choices then are to adapt and tailor a measure for a specific community, or in the case of if one actually wants to study and examine whether an intervention is achieving its objectives across multiple communities at the same time, is to come up with better person-centered measurement approaches. And I would argue a goal attainment scales is one approach. There might be others, but that's one that actually intrigues me a great deal in trying to address these issues of disparity, different expectations, preferences as it relates to utilizing these types of interventions, technology or otherwise.
Thank you.
Thank you. Great question. Yep.
Thanks so much for staying on a little bit longer,
Sure.
Joe. This is as a good webinar does. This has raised so many questions in my mind to think about. So
Great.
I really appreciate you taking the time to be here, and also thanks to folks for sticking on a little longer as well.
Thank you. And everyone, again, these slides will be shared. David, I'll send these to you if that's okay, or Jenna. And definitely reach out to me if you have ideas for our AI special issue. We're at the point now we're just gathering feedback. I've surveyed our editorial board. They've given some great ideas, but I'm sure many of you would too, vis-a-vis Mass AITC or the collective. And yeah, let me know your ideas. Love to hear more from you. So
Yeah, thanks, Joe.
you.
Thank
Okay.
you.
Be available.
Thank you, everybody.
There's a recording too that we'll share. So,
Wonderful. Thank you, everyone. Good luck with all your great work. Thanks for having me today.
Thank you.
Thank you.
Bye now.